Review prostate MR cases online. Answer each case according to our structured pro forma answer page. And then get immediate feedback against a radical prostatectomy. 300 cases, track your progress, earn CME points. Visit mripro.io.
Welcome to yet another free webinar brought to you by MRI Pro. My name is Jeremy Grummet, one of the co-founders of MRI Pro. I'm also a urologist at Alfred Health and Monash University here in Melbourne, Australia. Now, for those of you who don't know much about MRI Pro, it's an online learning platform of 300 cases of prostate MRI, each one of them with full histological verification. So I just want to show you all, just while all of our attendees are joining us, just a short ad on what MRI Pro looks like and how it actually works. So
Review prostate MR cases online. Answer each case according to our structured pro forma answer page. And then get immediate feedback against a radical prostatectomy. 300 cases, track your progress, earn CME points. Visit mripro.io.
all right, so I hope you're all able to see that. Now we have assembled yet another stellar cast for this webinar, this time predominantly University College London, experts in prostate MRI. So I will be introducing you guys one by one and then we'll get going. First up, we have Dr. Clare Allen from UCL, who's one of well known to us at MRI Pro. She's been on as a panelist before. Claire is a world expert in prostate MRI and well known also in the field as a superb educator in this field and regularly delivering workshops for prostate MRI. So Claire, thanks for joining us.
Thank you. Thank you for inviting me.
And Claire, your colleague, your partner in crime, Francesco Giganti, also from UCL, is a associate professor of radiology. And Francesco, you did your PhD looking at the role of serial MRI during active surveillance. That's a precise criterion. We're going to be talking a bit about that today, actually. And also exploring the issue of prostate MRI image quality. So that's, do you call it PI-QUAL or PI-QUAL? What's the pronunciation of that?
Thank you, Jeremy. We tend to call it PI-QUAL, but PI-QUAL is fine, no worries.
Francesco actually received the 2020 Prostate Cancer Foundation Young Investigator Award. So he's a rising star, a risen star in this field as well. So we're thrilled to have you on the session as well, Francesco.
Thank you, Jeremy.
And then, of course, we've got Veeru Kasivisvanathan, also from UCLH, but actually living and working with Declan, who I'll come to in just a moment, at Peter Mac here in Melbourne this year. I'm sure Veeru is well known to all of you as the NIH Academic Clinical Lecturer in Urology and Hunterian Professor in 2020. He completed a PhD looking at the role of MRI-targeted biopsies in the diagnosis of prostate cancer and basically ran the precision study, which you will have seen published in the New England Journal of Medicine. Veeru, you're now running the PRIME study. And as I said, you're doing the fellowship with Professor Declan Murphy, who's also joining us. Declan, thank you for joining us in this session. I'm looking forward to hearing your commentary. Many of you will know Declan as the Director of GU Oncology at Peter Mac, but also Director of Robotic Surgery at Peter MacCallum Cancer Centre, but possibly even more notably recently as the global roving reporter for basically anything urology. So if you see Declan with a microphone, he'll be at a conference somewhere around the world. And Declan, you've just got back from Lugano, is that right?
Yes, thanks, Jeremy. Thanks for the invitation to come back on this fantastic webinar. Yes, we run a podcast called GUcast that you've been on a number of times as well. And now that the pandemic is finished, not just do we post a regular podcast, myself and my colleague, Dr. Renu Eapen, but we are popping up at conferences and bringing conference highlights. And indeed, we'll cross-post this episode of MRI Pro on the GUcast platforms as well. So thank you.
Oh, no. Well, thanks for doing that. I think that, you know, the service that you guys provide with GUcast in terms of, you know, getting the message out for the latest developments that are happening in urology is actually fantastic. So well done and keep going. So finally, a bit of housekeeping. We're going to do things a little bit differently. As I said, I'm going to take a little bit more of a backseat this time and let our experts from UCLH run the show. And we'll be trying to take as many comments and questions from you in the audience as we possibly can as we go through. So please use either the chat or the Q&A function on your computer to send in your questions. The webinar will be going for about an hour or so. It'll be case-based, but we will have a little bit of didactic discussion as well with regard to PRECISE and PI-QUAL, as we talked about a moment ago. As with all of these webinars, we record them and we'll post them on the MRI Pro website a few days later. So in addition to this one, we've already got more than 10 other webinars that are freely accessible. So please go there to check it out. So without any further ado, let's get cracking on this session. Francesco, would you like to take over and share your slides?
Yes, sure. Thank you.
Oh, while you're getting your slides up, I've just forgotten my colleague, Richard O'Sullivan, who was a bit of a late join to the webinar. Richard was having a few internet issues, but Richard, apologies for not introducing you. It's because your mug's not on the screen, I think. But Richard O'Sullivan is our local prostate MRI expert. He is the director of Bridge Road Imaging, which comes under the banner of Loomis Imaging here in Melbourne, Australia, where they read more than 2,500 prostate MRIs per year. Richard, welcome. Thanks for joining us.
Oh, thanks, Jeremy. Sorry, I did have a few IT issues, and I haven't got a camera on this particular computer, so I'm interested to hear what's ahead.
Francesco, take it away.
Oh, okay, thank you. Just share my screen. So can you see my screen?
Looks good.
Okay, perfect. So basically in this, in this hour or so, we will just have a look at some prostate MR cases for this webinar. But the first thing I want to introduce actually is the two scoring systems that we have just mentioned. So the PI-QUAL score for prostate image quality and the PRECISE score for the assessment of radiological change on axis of veins. So these two scores, as I said before, were the big chunk of my PhD, and we developed these two scoring systems at UCL and also with our international partners. So we know actually the importance of prostate MRI in the diagnostic pathway, and now MRI is recognized as a very important tool, both in Europe, in America, Canada, and Australia as well. We also know that there will be a huge demand of prostate MR scans in the next years. And you also know all these publications that are cited here in terms of the role of MRI in the pathway for diagnosing prostate cancer. But it is also very important to stress that the quality varies between centers and scanners. And we know that if you have a poor image quality scan, you will have a great uncertainty and a lower accuracy. So we need to perform our MR scans at a high standard. I also like to show this timeline because actually in the last 40 years, prostate MRI has improved a lot. So the first studies were from 1971 or 1982 in the human. And basically over these years, there have been a lot of advances in terms of new sequences and in terms of how we do prostate MRI. So this is a scan from 1987. You can barely see the peripheral zone, the TZ here, the bladder and the rectum. In 2022, as you can see here, things are much different and much better. As radiologists, we refer to the PIRAS guidelines in order to improve the quality of our scans. And we know that the multiparametric prostate MR scan is made of 3 different sequences, T2, diffusion, and DCE. So if we stick to the version 2.1 published in 2019, so the latest version of PIRAS, we have minimal technical requirements for each of these sequences. Some of them are in common for all the 3 sequences, meaning that the slice thickness might be, for example, 3 mm 42, less than 4 for diffusion, and 3 for DCE. But then we also have some specific recommendations according to the different sequences. So for example, 42, it is useful to acquire another plan in addition to the extra plan. For diffusion, we have dedicated high B value sequences that should be acquired. And for DCE, we have some recommendations, like, for example, fat suppression or subtraction. We conducted a review over the last 5 years of the role of image quality in the literature, and basically we have seen that there are a lot of conflicting results in terms of MR sequences, patient preparation, but also in terms of how we score the quality of the scans. So many of these studies use a 1 to 5 scale that is in-house made, but there are no standardized scoring systems. So this is the reason why MRI from this review must be high at the center level, so using up-to-date MR scanners and dedicated and experienced radiologists or radiographers, but also at the patient level, so we should minimize the presence of artifacts. Our initial work done by an engineer, dedicated engineer, Vasily Tapsaki, helped us in standardize our London network. Basically, what we did for this study was to evaluate across 23 MR scanners in 14 different hospitals the quality of the scans, and we saw that pre-optimization, 15% of T2 weighted images, for example, were non-diagnostic, but up to 50% of high B-value sequences were non-diagnostic. After optimization, meaning that we applied the PI-QUAL score, the PIRAT's recommendations, and we improved their quality, you can clearly see here that there was a huge improvement in terms of image quality for all of the sequences. So this is the reason why we came up with this scoring system called the PI-QUAL score. So the scoring system was created from the precision trial that you all know. And basically PI-QUAL is a 1 to 5 scale, as you can see here, that evaluates the quality of the 3 different sequences, T2, diffusion, and DCE. More in detail for each of the sequences, we have some technical parameters that we need to check, and also a more subjective part made of a visual assessment of some anatomical structures. So in terms of the technical parameters, you can see here for T2, diffusion, and DCE, we make reference to the PIRAT's recommendations. So the scan should meet all of these parameters. In terms of the visual assessment, and we will see some cases with Claire after my talk, we have some anatomical landmarks that we should look at, for example, the SVs and the ejector ducts of the capsule. For diffusion, we do not have any anatomical landmark, but we have to evaluate the quality of the ADC map and if there are artifacts or not. For DCE, we have some anatomical landmarks like the capsular vessels or the vessels in the Alcox canal, but also again, the absence of artifacts. And the PI-QUAL score, as I said before, is a 1 to 5 scale. And as you can see here, if we start from low PI-QUAL scores, so meaning 1 or 2, the first thing we have to see is that for a PI-QUAL score of 1, none of your sequences are of diagnostic quality. While if you have a PI-QUAL score of 2, means that only 1 of the 3 sequences is of acceptable diagnostic quality. But the most important thing here is that there is a clinical implication that it will not be possible to rule in and rule out all significant lesions, meaning clinically significant prostate cancer. So in this case, you should not include PIRATs or Likert if you're using Likert scores. If you have a PI-QUAL score of 3, means that at least 2 MR sequences taken together, so T2, diffusion, and DCE, 2 of them are of acceptable diagnostic quality. And here we have a slightly different clinical implication. So it will be possible to rule in all significant lesions, but not to rule out all significant lesions. And the key word here for PI-QUAL is all. PI-QUAL score 4 or 5 means that the quality of your scan is good. So you have 2 or more sequences independently of optimal diagnostic quality, or if you have a PI-QUAL score of 5, all of your MR sequences are of optimal diagnostic quality, meaning that all the boxes are ticked in the scoring sheet. The clinical implications for a PI-QUAL score of 5 is the same. It will be possible to rule in and rule out all significant lesions. We know that PI-QUAL will undergo further refinements. We are working on version 2, but at the present, PI-QUAL is the only first standardized scoring system. We also published the practical primer for radiologists or radiographers and those involved in the diagnostic pathway. You can easily download it from the website because it's open access. Very briefly, some brief images of what we look at when we evaluate the quality of the scans. In terms of T2 weight imaging, we have a visual assessment. So if you have a good quality MRI, you should have clear delineation of the pseudocapsule here and the neurovascular bundles. Same for the SVs, that should be well seen on the axial T2 weight imaging, as in this case, or the ejector ducts. Look at both ejector ducts here. You can clearly see them. You can also see the muscular coating around them. And also the sphincter, so the external urethral sphincter that we usually evaluate on coronal imaging. You can clearly see these two hypointense black stripes here. There can also be some artifacts on T2 weight imaging, and here you can see some motion artifacts. You can see that the quality here is hampered by these artifacts, and also some artifacts here from metallic implant in the right hip. Diffusion weight imaging is the second sequence. We know that diffusion weight imaging looks at the motility of water molecules in tissues. And if you have prostate cancer, you will have a high signal on the high B value and the low signal on the ADC map. In terms of the adequacy of the ADC map, here you can see a low diagnostic, actually non-diagnostic ADC map. And here you can see a good quality ADC map where you can differentiate easily the PZ from the TZ. There can be artifacts also on diffusion weight imaging. Here you can see artifacts from metallic implants on the B values and the ADC map. And basically this scan is non-diagnostic. And here you can see some artifacts from rectal gas that prevents you from assessing the posterior part of the left prostate. Finally, we have DCE sequences. As you know, DCE sequences are the sequences acquired after injection of contrast. It is very important to have a pre-contrast T1 weight imaging in order to rule out the absence of artifacts from post-biopsy. But also another very important thing is fat suppression or subtraction. So here you can see this is a non-fat suppressed image, and this is a fat suppressed image. You can see that there is an artifact here before the contrast reaches the prostate. There is an artifact in the right anterior horn, and this is well seen in the fat suppressed images, and these artifacts are after biopsy. It is also very important to state that the temporal resolution should be 15 seconds for PI-RAS version 2.1 guidelines, meaning that the time between two acquisitions of the same slice should be 15 seconds or less. So this is very important because we know that prostate cancer has an early wash in and an early wash out. So if you have, for example, like in this case, a temporal resolution of 30 seconds, so 30 seconds between each sequence, it will be impossible to depict any focal area enhancement, which is characteristic of prostate cancer. We also have some anatomical landmarks for DCE. So here you can see a clear delineation of the capsular vessels here, and here you can clearly see the pudendal artery in the Altox canal. So these two landmarks are very important to evaluate the quality of your DCE sequences. And finally, you can also have some artifacts on DCE. And in this case, for example, you see some artifacts from metallic implants in the right hip again, and here you can see some ocean artifacts. In terms of the literature that we have, there is a very interesting paper from the group from Cambridge. Basically, they assess the clinical impact of PI-QUAL, and you can see here that if you have a higher PI-QUAL score, you will have a higher call for negative MRI. In terms of indeterminate calls, PI-RAS 3, if you have a good quality MR, you will have an inferior number of indeterminate MR calls. And this actually is reflected also from the number of MR lesions biopsied. So if you have a PI-QUAL 3, which is exact diagnostic quality, you have a higher number of PI-RAS 3 and PI-RAS 1 or 2 that get biopsied. This is different for PI-QUAL 5, so great quality MR. And finally, in terms of number of MR scans repeated, you can see that if the quality is bad, you will have up to 80% of your scans that are repeated, while if you have a good quality MR, only 4% of the scans are repeated. And here, very briefly, the second part of this presentation is about the precise score. So basically, we conceived the score in 2016 with Caroline Moore and the group of other urologists and radiologists, radiation oncologists. Basically, the idea behind this scoring system is a scoring system to evaluate the radiological change over time. And basically, the radiologist should fill this dedicated scoring sheet from the second MR onwards, because you have to compare your current MR with the baseline and the previous MR. In this case report, the radiologist can note all the values that we need, for example, the PSA and the prostate volume to do with the imaging, but also should score up to 3 lesions and evaluate the radiological change compared to the previous or baseline scan. And for each lesion, the radiologist should give 3 different diameters and evaluate the volume by planimetry, meaning that you contour slice by slice the lesion, but also with a simpler formula, the ellipsoid formula. Here you give your Likert scale or your PI-QUAL score, and it's very important to state where the lesion is best seen. So, and where the volume is best seen, and also on T2-weighted imaging. And the last bit of the scoring sheet is the most important part, because in this case, you evaluated the radiological change. So you give a precise score here, and you state which parameter has changed, volume, visibility, or disease progression, stage progression. And so again, the precise score is another 1 to 5 scale. And as I said, it's from the second MR or worse on serial MRI on active surveillance. In this case, we start from a precise 3. Precise 3 means that your MR is stable, there are no new lesions or on diffuse lesions, or your tumor has not changed in terms of size or appearance. On the other hand, if you have a precise score of 1 or 2, you have radiological downgrade, meaning that if you have a 2, you will have a reduction in volume and conspicuity, but there is still some suspicious for clinical prostate cancer. If you have a Likert score of 1, means that you have no longer features suspicious on MRI. So for example, previously enhancing area that no longer enhances. Things are different for precise 4 or 5, when you have a significant increase in size and conspicuity. So for example, lesion becomes bigger, or there is a new lesion, and so this is going to be precise 4, radiological progression. Or a precise 5, when you have definitive radiological stage progression, so appearance of extracapital extension or SV involvement. So now we will move to the first case that I have here. Basically, it's a case of a 66-year-old man who is on active surveillance since September 2019. So we know that he has 1 millimeter Gleason 3+4 on the right and Gleason 3+3. And the biopsy was made in September 2019. There is no disease on the left. So the first MR, we will see now, shows a volume of 51 cc, a PSA density of 9.68, and a PSA density of 0.19. And the PI-QUAL score of this MR, you will see, is a PI-QUAL 4, meaning that it's a good quality MR. So basically here you can see the T2-weighted imaging. Here you can see the diffusion-weighted imaging, the high B value, the ADC map, and the DCE. So if we start scoring the scan using a systematic and standardized approach, we start scrolling down from the base towards the apex, and we look at the PZ and the TZ. We just adjust the contrast a bit. And we look for, because as you can see here, there is no contrast here yet. So we look for the first sequence where we can see the contrast in order to see any focal early enhancement. So we know from the PIRAS guidelines that we have 2 different sequences for the PZ and the TZ in terms of dominant sequence. So for the PZ, the dominant sequence is diffusion. For the TZ, the dominant sequence, as you know, is T2-weighted imaging. So we will have a look at the anatomical sequence here, which is a T2. So what we can see basically is that there are no focal lesions in the TZ, so there are no areas concerning. While in the PZ, you can clearly see the hyperintensity of a PZ. The only thing that we might see is something here in the midline. So we know that the dominant sequence for the PZ is the diffusion-weighted imaging. So if we have a closer look at the high B value sequence, we can see that there is nothing flashing here on the high B value sequence, but actually there is something showing hypointensity on the ADC map. And if we have a look at the contrast, we can see that there is some enhancement here. However, it's not a very bright enhancement, a focal enhancement. So in this case, we can see only some enhancement in the right PZ at midline with this focus that does not show any restricted diffusion of the high B value, but shows some mild restriction on the ADC map. So the scoring, the score of this lesion is a 3 out of 5 on a PIRAT scale. And in terms of quality, you can see that the quality of the scan is good. It's a PI-QUAL 4 or 5 because basically, sorry, PI-QUAL score of 4. There are only some minor artifacts here, but the quality of the scan is good. So the original report said there is more 3 out of 5 in the right PZ at midline. So all options were offered to the patient because of his PSA density, and the patient opted for active surveillance. So after 2 years, he had the second scan that we are going to see now. The PSA rose to 11. The prostate volume was similar, and the PSA density rose to 0.20.
Just while you're getting that up, Francesco, Veeru, in terms of the biopsy that was done, how do you, can you just perhaps for the urologists in the audience, how would you have done that?
Yeah, so most of, all of the biopsies now at UCLH are transperineal, typically either with sedation or under local anesthetic, the majority probably under sedation. The area of suspicion would have been highlighted by the radiologist in advance on either a diagram or marking on the images. And they would have taken targeted cores from that area. So on average, probably about 4 targeted cores per suspicious area. And depending on who's done it, they may take some systematic biopsies, focusing on the peripheral zone, particularly on the contralateral side where there is no biopsying of the target.
Declan, do you do anything different?
No, but certainly we would want to know a little bit more about the biopsy. It was a grade group 2 cancer, but the percentage pattern 4 and the presence of cribriform morphology or not would also be really important determinants of suitability for surveillance as well in our practice.
Yes. Sorry, back to you, Francesco.
So, okay, on MR, the second MR, we can see now that we have 2 discrete lesions in the peripheral zone, 1 and 2. So at midline and 1 at 8 o'clock. So if we have a closer look at the high B value sequences, we can now see 2 lesions here, characterized also by hypointensity on the ADC map. And if we have a look at the DCE, you can see the 2 lesions flashing here. Let me see if I found a, yeah. So you can see the contrast here is very helpful. So it's showing us the 2 lesions here. And there is also some diffuse enhancement in the right PZ. So in this case, so we saw basically that there was a new lesion. A lesion has increased in size. And so we mentioned that this was a 3 out of 5, now it's increasing in size. There is also a new lesion here in the right peripheral zone. So this is an increase in conspicuity and in size and new lesion. So in this case, you see that the 3 foci were described, scoring 4 out of 5, and then some diffuse right enhancement in the right apex. So this was the precise 4 that was biopsied. I want to stress again that the quality of the scan was good. It was a PI-QUAL 4 again. So we had 2 scans, PI-QUAL 4, good quality MR. And this is the biopsy plan that Veeru was referring to. This is what we usually do. So we draw the lesions on a diagram, and then for a visual registration, those who are performing the biopsy use this and the MR images. So here you can see the results. It was a Gleason 3 plus 4, 2 out of 3 cores from the first area, 6 to 7 o'clock. Second was again 3 plus 4, 2 out of 5 cores, 7 to 8 o'clock. And the right apex, there was again 3 out of 5 cores, Gleason 3 plus 4. There was also 1 out of 4 cores of Gleason 3 plus 4 on the left. So in this case, again, patient was offered radical prostatectomy versus active surveillance, and patient opted for active surveillance. And so he had another MR.
How far apart are these MRs that you're getting done? I know you're putting the dates on, but just to remind our viewers.
So the first one was in 2019, then after 2 years, 2021. The third MR that we are now going to see is 2022, only after 1 year. I will show at the end our MR based active surveillance pathway.
Okay, great.
Whilst he's getting that up, it's typically all of our patients will have an MRI at baseline, and thereafter 1 year. The decision to biopsy and do confirmatory biopsies, we don't really do confirmatory biopsies. Decision to biopsy thereafter is based on MR and or PSA and or PSA kinetic changes. So one of a combination of those things. The MR, the third MR will typically be at 3 years. So baseline 1 year and 3 years.
And so those MRIs, Veeru, are regardless of the PSA. I mean, obviously the biopsy is dependent on the MRI, but are the subsequent MRIs dependent on PSA, or do you just get the 1 and 3 years regardless if they're on active surveillance?
That's a typical approach, but we do tailor it for particular patients. So if there's a reason to bring an MRI forward earlier, for example, we can do that.
Yeah, I'm just showing now the slide, sorry, with our pathway, if Veeru wants to comment.
Right. Okay, yep.
I don't know if Veeru, if you want to comment on this graph.
Yeah, looks reasonable.
Yeah. So basically, I think here, Veeru, correct me if I'm wrong, but I mean, the key thing here is the visibility of a lesion at baseline. So basically, you have a baseline MR, and then you have an MR at 12 months. Then if you have a visible lesion at baseline, you will have a third MR at 24 months. If you do not have any visible lesion at baseline MR, it's based on PSA density or other PSA changes. Because we have seen our cohort that if you don't have a visible lesion MR, you tend to progress less than those who have with a visible lesion on MRI, both for Gleason 3+3 and 3+4.
I think that's a critical point, Jeremy, because the cohort that we published was just under 700 patients. It was published in European Urology, looking at the longer term outcomes of patients on active surveillance. And one of the key outcomes was that the visibility of the MR lesion does relate to outcomes such as metastasis and survival. So the non-visible 3+4s, which were low volume to be considered for active surveillance, actually behaved pretty much like the 3+3s. And that's an important determinant of why we have a slightly different protocol for whether the lesion was visible or not.
Yeah. No, that makes a lot of sense to me. I'm just wondering whether even with a lesion at baseline, I'm just reflecting on my practice. I think unless there was a significant change in PSA, I'm not sure I would go ahead with further MRIs. Declan, how about you? What's your perspective on that?
Yeah, look, this is nice work, but I think it's very important not to be too focused on these image-guided pathways when, in fact, this is a patient with intermediate risk prostate cancer. He has visible 3+4 cancer. As I said, we'd want to know a lot more about that, about the percentage pattern 4, maximum core length, and especially the presence of cribriform. In other words, things that aren't to do with imaging. Although he has had a visible lesion, now a more obvious lesion as time's gone on, PSA rising, more 3+4. You know, I think to adopt a pathway, as Veeru said, that they would not routinely do a biopsy here, I think is well outside guidelines. We should just remember that if you're selecting an otherwise fit patient for active surveillance with this type of visible intermediate risk prostate cancer, at the very least, a confirmatory biopsy is recommended regardless of imaging findings, but especially if the imaging is showing a lesion, I would say. So let's just remember there's more to active surveillance than just imaging.
Yeah, so I think Declan's highlighted a few good points there. So, you know, there are circumstances where if you've got a man with low volume 3+4, you may be less likely to keep him on active surveillance. And some of those variants of prostate cancer, intraductal prostate cancer, cribriform prostate cancer are good examples. I think if you look at the EAU guidelines and things like a detective consensus meeting, which look at how we should manage patients on active surveillance, I think generally there is a recommendation in a detective consensus meeting that if you have good baseline MR, systematic and targeted biopsies, they do not necessarily need a confirmatory biopsy. I think the practice at UCL is probably not necessarily exactly in line with the guidelines, but I think what we do know from the work we've done over the last decade or so is how good the MR is to be able to kind of adapt how we view some of the evidence.
Richard, if I can just bring you in on this conversation just while Francesco's loading those images. Richard, do you see many patients in Melbourne here who are getting serial MRIs in the context of active surveillance?
It's become certainly more popular. Active surveillance came on the MRI schedule for MeCare about the same time that diagnostic prostate MRI came on. So over the last couple of years, it's now more common, but I would not say every year. I would say every 2 to 3 years would be more common unless they've been driven by an abnormal DRE or an abnormal PSA.
Yep.
But yes, it's a significant subgroup, yes.
Okay, thank you. Francesco, please go ahead.
Yep. Okay, so now you can see the third scan here. So the first thing we have to say about this scan is this is a 3T scan, while the other ones were from a 1.5T. So we can see a better quality of the T2 imaging, although the quality was already good with 1.5, the 1.5 scan. So, and again, we can see the lesion here on the right. And we can clearly see the lesions flashing here, but there are no new lesions. So if you scroll from the base towards the apex, no new lesions were observed despite the increase in PSA density. So if we compare this scan which is a PI-QUAL 4 again, to the baseline scan, it's a precise 4. If you compare to the previous scan, it's a precise 3. So stable lesions, but again, there has been radiological progression because we always have to compare our scan with a baseline. So at the end, we offered this patient radical prostatectomy, and the patient opted for radical prostatectomy, but he has not been operated yet. So this was the first case.
I don't want to steal your thunder, Claire, but I'm just wondering, just in terms of the PI-QUALs that we're looking at, how that actually plays out in clinical life. In other words, you know, we can obviously rate MRIs on their PI-QUAL scores, but is the idea of having this that it's going to try to change practice and make radiologists more aware? And how is that actually playing out in your clinical practice? I understand that, you know, there is a wide variety of quality, but I'm trying to understand how the PI-QUAL scoring is actually going to change practice for the better.
I think one of the ways that we are using it, and we hope that people will use it, is a way of allowing the institution to know that against a baseline quality, the scanners are not performing appropriately. We've got some good data now to show that if you don't have a PI-QUAL 4 or 5 scan, you are likely to miss lesions. In our institution at the moment, we have 8 or 9 MR scanners. We are aware that some of them are better than others. We're currently doing an audit, and what we're going to try and show is that some of the scanners should be not used for prostate imaging. And I also think it's a way that institutions can look at their scans, assess whether or not those scanners can be upgraded to a better PI-QUAL score, and then if they can't, make a case that the institution needs to get a different scanner or needs to upgrade the scanner. So I think that there's lots of different ways that we can use it. We haven't had any metric before. We've just had a thing, oh, we don't like the look of that one, or that one's not very good. But we needed to have a metric that we could measure against to say that the scans weren't of good quality. I think the other thing that's been, I think, quite disappointing is that the manufacturers themselves haven't embraced giving us good quality scans from the get-go. So unlike CT, when you put in an MR scanner, it's really not plug and play. They have some sequences that they download for you, and they say that they are PI-RADS compliant, but PI-RADS compliant does not necessarily give you a good quality scan. And I was very disappointed recently to sit next to an application specialist from one of the manufacturers that was delivering to us, and all he could talk about was what we could get away with, how quickly we could do the scan, you know, how we could get away with doing the scans quicker. And when I pointed out that actually that meant that the quality wasn't so good, that really wasn't what they were concerned about. So it also gives the radiologist a way of assessing the scan and saying to the applications, this isn't good enough. We need to increase the number of averaging. We need to, for example, there are quite a lot of quick fixes for the ADCs and for the gadoliniums that makes the scan better. As you know, gadolinium is a really big debating point, and Veeru very kindly has set up yet another study, which we're just recruiting to now, PRIME, in order to try and work out whether gadolinium is necessary or not. My feeling is that as we try and get away with poor quality T2 or diffusion, gadolinium may become much more of a necessity. But yes, I totally agree with your comments, and I'm just hoping that PI-QUAL will give people a framework to work with.
I might add one more comment, Jeremy. In addition to the clinical practice point of view, we've got to think about when we synthesize the data and run clinical trials in MRI. The basic premise of whether or not your biopsies are going to be good and detect cancer is whether the MRs are good. And to date, it's quite hard to tell that from any piece of work. So if you're running a big multi-center study, it's probably important to have some kind of quality control, and maybe at baseline, maybe at the end of the study, but to show people this is the level of quality of MR within this study. This is or this isn't applicable to what's going on at my center.
Yeah. No, that's fantastic. I think Claire, later on, Francesco, Claire, you're going to show some poorer quality images today as well. Is that right?
Hopefully, yes. If we've got, we might have to come back. You might have him.
Right,
you might have to. You might have to invite us back.
Can I just ask one thing about quality?
Yeah. Go, Richard.
So the most important thing is the diffusion rate imaging. I think that gives us about 90% of the information. Do you weight the quality based on those, or is that each of the three sequences weighted equally?
So we have a system where the three sequences are weighted equally, and we understand that on the PI-RADS scoring system, the gadolinium enhanced study does not form much of the diagnostic discriminator on many of the sequences. I have to say that we feel that that's probably downgrading the degree with which you use gadolinium, and we've got some good data, and there's some data coming out showing that gadolinium will help you with staging in terms of capsular enhancement and seminal vesicle disease. And it becomes very important that the gadolinium enhanced scans are of good anatomical quality. It was really interesting. Francesco and I did the quality assurance for PRIME, so in order to be part of the PRIME study. And I think for the very first time, we have assessed the quality of every single center entering scans for PRIME. And I suspect that this now will become, as Veeru said, a prerequisite for MR studies that are multi-institutional, and indeed from a single institution, that you've actually proved that the sequences that you're using are of adequate quality. For example, it's very difficult to do a study such as PRIME when you're trying to see whether or not gadolinium is helpful, when most studies, most centers, the gadolinium enhanced scan was the worst quality. So you weren't actually assessing the benefit of gadolinium. You are actually assessing the quality of the diffusion versus the gadolinium. So it was very important during PRIME that we balanced the quality of the diffusion and the quality of the gadolinium. So it wasn't a quality study, it was a study on gadolinium. And I think probably going forward now, all of the MR studies will have to have some sort of quality metric included, so that we know that we're not muddying the waters by having quality issues rather than actually looking at what the scan's showing.
Sorry, thank you, Claire. And just leading on straight on from that, and I'm sorry to sort of delay things here, but this is very relevant. So I've got a question in from the audience saying, are there any guidelines to improve image quality if the PI-QUAL is low? Well, that's pretty much exactly what you were talking about before, Francesco, wasn't it? In terms of all the different criteria or stipulations that you can use. That was in your publication, yeah?
Yes, correct. Yes.
Yeah,
So
and I have to say, from our point of view, we have found it very helpful to have a physicist actually helping with us. I think that there are two issues with the quality. I think if you have a scanner that's over 10 years old, it's going to be really difficult to get your scanner up to a 4 or a 5 unless you've had an upgrade to your magnet and to the coil technology. We think that it is going to be very, very difficult on the older scanners to do that. There is some variation between the different vendors, and some of them are certainly easier to set up than others. I think that quite usefully, we could set up banks of scanning protocols to help each other. We've all got machines that are very similar, and sometimes it feels like we're reinventing the wheel, and some people are doing very good scans. We found that with Prime. Some people on exactly the same scanner are doing very poor ones. So that sort of variation, I think we could, as a community, look at very carefully and see if we can help each other. And I think, there are easy things that the radiographers often do. So they don't like long scans, and quite a lot of the time it's just simple stuff like averaging. Making sure that, you're taking enough averages. Sometimes it's just the way that the fat saturation's done. So lots of easy little tweaks that you can do to get your scan quality better.
If I could just say, in Australia, the government doesn't reimburse on an MRI scanner if the MRI scanner is over 10 years old.
Yeah. Yeah. I think that's, yeah, it's good.
Francesco, carry on.
Yeah, so the second case is quicker. So we have a 53-year-old man who is on active surveillance from September 2011 for 1 millimeter lesion 3+3 in the left apex. There is no disease on the right. So as you can see, he has had several MR scans. We're not going to go through all of them. And you can see that the PSA density has been pretty stable. So we will have a look at the MRI from 2019, because all of these scans were scored precise 3, so there was no radiological change over time. So what we can see here, so this is a 1.5 Tesla study. We can see diffuse changes in the PEZ bilaterally, and we cannot see any focal lesion here. And on the high B value, there are no focal areas of hyperintensity or focal area of hypointensity in the PZ on the ADC map. You can also see diffuse enhancement here, but again, no focal lesions. So this scan was called as diffuse changes, but no focal lesions. So it was called the precise 3 compared to the previous one. Then we have the latest scan from April 2021 with the PSA stable. Now we will have a look at the quality of the second MR. So PSA stable, and he had another MR according to our protocol. So again, this is a 1.5 Tesla study. Now on this scan, we can clearly see the presence of rectal gas, especially on T2 weight imaging. You can see that the rectum is full of stools and air. And you can see that the background has improved. So the PZ now is is more visible. Basically, the hyperintensity of the PZ on T2 weight imaging is more visible. And at the same time, if we have a look at the dominant sequence for the PZ here, we can see some restricted diffusion here on the left that corresponds to this area of low ADC here, and also corresponds to this area of enhancement, although the enhancement is bilateral. But the striking thing here is that the quality of the scan is not adequate, because you can see that a lot of the rectal gas and stools basically gives you this artifact in the posterior part of the prostate. So you are not able to discriminate the presence of a lesion or the presence of artifacts. So we have a stable PSA, and we have an area of low T2 signal intensity and restricted diffusion with mild enhancement. If we have a look at the coronal sequence, we can see that the area we are referring to is this area here. But again, there is no enhancement, and we have this the presence of these huge artifacts from rectal gas and stools, and also some motion artifacts. So actually here, T2 weight imaging and diffusion weight imaging are not of adequate diagnostic quality, although there is a great sequence, which is DCE. You can clearly see the vessels in the Alcox canal. You can clearly see the capsular vessels here. So the best sequence for this study is DCE. So this case, so this MR was called as a PI-QUAL 2 because only DCE is of adequate diagnostic quality. And you can see that 2 lesions were scored, so a 4 out of 5 in the left PZ. And also there was a tiny right PZ at midgland at 8 o'clock, scored 3 out of 5, and then diffuse 3 out of 5 changes the right anterior horn. But again, we have to stress that the quality of the scan was not adequate and the PSA was stable. But as it was a patient active surveillance, we had to give a precise score. And in this case, we gave a precise score of 4 because the background has changed. And now there is a focal area in the left PZ at midgland scored 4 out of 5. So you can see our biopsy plan here, and the reclassification biopsy done in September 2021 said there was no evidence of malignancy. And actually, so the PSA was then 4.54 in June, and then dropped to 2.09 in August and 1.66 in February 2022. So the patient now is still on active surveillance, and he has been biopsied because of the presence of a lesion that maybe was due to the presence of artifacts. So just to conclude my talk, and then we can discuss and see other cases, we know that quality assurance and quality control should be implemented for every step of our diagnostic pathway, starting from the image quality with PI-QUAL, and then interpret your MR scans using PI-RADS, then prepare your data using a biopsy plan as we have seen, and then do your own biopsy procedure and correlate all your findings with histopathology. So the three questions that we should ask ourselves as radiologists and urologists, I think, is if the quality of our MR examination is adequate, so the PI-QUAL score, and the quality of my interpretation good enough. Am I using a Likert or PI-RADS appropriately? And if my biopsy procedure is okay. So for these, the best thing that we can do is to attend weekly MDT meetings and have a regular cancer detection rate for evaluation for each PI-RADS score, especially when we have 4 or 5 that are negative on biopsy, like in the last scan that we have seen, and also the importance of number of PI-RADS 3 category lesions. So we know the prostate MR quality is a key point in this diagnostic pathway. So for the radiologists, it is very important to be aware of the PI-RADS version 2.1 technical details, and also it is very important to assess the image quality during the acquisition to repeat, if needed, the scan. And PI-QUAL, we know, is the first data scoring system. And but as I said before, further refinements and version 2 are underway, and will also include some elements of lesion detection impact that this quality will have in clinical practice. And you have seen our pathway. So radiological saint is used using the precise score, but we know the image quality must be good. So PI-QUAL 4 or 5 if you want to have a good assessment of your radiological change. So thank you. So this is the end of my part.
Francesco, thank you so much for that presentation. That last case really brings up, I guess, what I was trying bring up before in terms of how you actually use PI-QUAL in the set? I know Veeru's answered that from a research point of view. It's critical that we can actually measure the difference in quality of MRIs, but in practice, this guy had a PI-QUAL 2 MRI, but went on to have a biopsy anyway, which was negative. And I suppose my question is, if you do have a PI-QUAL 1 or 2, should those MRIs be repeated? What are your thoughts on that?
So my thought, and I'm very happy to see if Claire agrees with me or not in Veeru, but basically the thing here is that in this case, for example, I would have repeated for sure the scan. And so this is why I said that the radiologist should check the scan when the scan is acquired. The problem here was on diffusion weight imaging. So there are, as we saw in our review, some attempts to reduce the presence of this kind of artifacts and basically using, for example, enemas or basically putting a small catheter in the rectum. But this is not, we don't do this at UCL. The other thing that we have to be aware is that sometimes you can have a low quality MR scan, PI-QUAL 1 or 2, but if you have a very big lesion, scoring 5 out of 5 at 2 centimeters in lesion, you are still able to see and biopsy the lesion. So this is something that we should take into account. But again, you won't be able to rule in and rule out all clinical stimulation. So the key word in the PI-QUAL score is all, because you won't be able to score all the lesions. So I would have definitely asked for another MR in that case. Claire.
Yeah, so I might. Yeah, go on, Claire.
And I think we are getting better actually at repeating MRs in patients now. And we will often see MRs coming from other institutions and indeed from our institution as well, where we'll say, actually, that's just not good enough. We need to repeat it. So I do think that that's coming, but I do think it's something that we need to emphasize more and be more honest about as a community. And I think that part of that may be that we start to put the scores on the reports, because as the patients start reading their reports and they'll say, what's this quality score? You know, why didn't I get a better scan? I think they will also push us to be better.
Mm-hmm.
So I think the other thing to add, I'd say, is it depends on whether the abnormalities you've seen are reversible or not. So, for example, if they're patient factors like rectal gas, patient movement, you know, if you were to repeat an MRI, would it make a difference? That's the first thing. Secondly, say you've got like a hip prosthesis, and it's not likely to make much of a difference if you repeat a scan, and that's the reason why you've got those bad images. You might say to the patient, okay, we've got these MRI images, the quality is what it is. Repeating a scan may not make a difference, but we have this other information available to us. Let's make an informed decision on what the next best step is. In some cases, for those reversible changes, as Claire has pointed out, say, for example, the patient had a biparametric MRI without contrast. And just as you've seen in that example that Francesco gave, the contrast images really helped there. It might be the case that you say to the patient, let's do an MRI with a contrast sequence. And it may make a difference in how we manage you. So I think there are different circumstances in when you would and wouldn't repeat something. And I think particularly for institutions that receive patients referred to them from outside institutions, there's an opportunity there to make a decision as to whether to repeat imaging, because ultimately you're going to be managing that patient in your center. And if you're going to make image guided decisions, you want to have a bit of certainty as to the information that you're looking at. Is it of the highest quality for you to make that important decision for the patient?
Mm-hmm.
There's a very good comment in the chat about whether the radiographers could do it and whether they could be alerted at the time of the scan. And as you say, Veeru, for the sort of patient factors and sort of any other factors. And we are working on an algorithm and an AI system for doing that. So hopefully, because that would be, obviously very beneficial, that you've got something that actually sits on the magnet working out whether or not the scan is of good enough quality as it's coming through. And if there is a sequence that needs to be repeated, or there's anything that could be done at the time of the scan, that is obviously done. That's predominantly for patient factors, but I think that would be a good thing.
Declan, I know you've got to leave us, so I just wondered if you had any closing remarks just before you have to head off.
Yeah, apologies for having to leave a little bit early. Look, it's been really eye-opening to see that very high quality work from Fran and team on the PI-QUAL stuff. It's just such an important reminder that if we're making very important decisions in these image-guided pathways that we all believe in, you know, I don't think we go back often enough to ask those questions. So having a standardized system is really, really important. That's really, really good work. And I think all of us out there listening to this webinar should try and make sure we go back and do that quality assessment. And now we have a framework, and I'm sure we can post links in the show notes for this paper in European Urology, but it's been incredibly helpful to hear that talked through. So congrats again, Fran and Claire and team.
Declan, thanks so much for joining us. We'll let you go, but I really appreciate your input, and thanks for also fielding some of those questions on the chat. Much appreciated. Great stuff. I'll let you go. I just did want to follow up actually, Claire, on your comments, because there's patient factors and there's machine factors, and if you can obviously patient factors, you know, that you just have to deal with them, but the machine factors you would hope can be sorted out a priori, or at least there's some way. So I mean, using PI-QUAL to say, well, if the actual factors that are preventing a decent MRI are machine-based, then surely that needs to be sorted out before you carry on the service.
I absolutely agree, and it's difficult. I think it's interesting. It wasn't until we began to accept a lot of scans from lots of different institutions that we realized what the variety of scanning was. And I think you can sit in your own hospital never seeing anybody else's scans. And obviously scans that you might see in pages of a journal are slightly different because they are from, you know, a trial where, you know, and whatever. And I think you can get a little complacent and you don't realize the change. I mean, radiology, we're changing everything quickly. I mean, we must be one of the most dynamic fields in terms of just the changes that are going ahead. And I think, you know, it's things like this where we can get out to people, you can see the scans in real time. I think showing scans the way that we do and being able to look all the way through and scroll through, you can see the sort of quality. And I think with PI-QUAL, we've tried to give things to look for. So part of it is conspicuity of things. So you need to see edges, you need to see ejaculatory ducts. If you can't see the ejaculatory ducts on your T2, then your T2 isn't good enough. So easy things to look at to discriminate whether or not you're getting a good quality on those. And I think, you know, we found that by far and away the worst scan done is dynamic contrast. The variation in quality of that. So from my personal point of view, I'm not surprised that we don't use GAD very often, or people feel that they can do bioparametric scans, because the quality of the gadolinium was really poor. And I think when we did prime, the one scan that we had to change the most was the DCE. In order to have a uniformity in the way that we were looking at the scans. So yes, I think that's why seminars like this hopefully will reach a big audience and people will start to think about it and maybe look at their scans a little bit more critically. You know, we're all really busy, sadly, but if you know, if everyone just took a critical look at their MR and said, can we do this any better, go to see their radiographers, superintendents, and just I think that would be a really good outcome from today.
Sorry, Claire, are you happy to, have you got a few moments to show at least perhaps examples of these, you know, poor studies?
I can show, maybe just show one poor study, because then I think that just I'll just show you one, because I've got my thing's about half an hour again, so we'll take a return trip, Jeremy, if that's
Absolutely.
all right.
No.
I'll just show one bad study maybe, and then maybe one just the effect of gadolinium on a bad study. So I'm just going to share my screen. Hopefully that will share. So I'm just going to show you one bad study. So I'm not, some of the manufacturers, it's easier to have good studies than others. I think in the last sort of, if you've had a scanner put in within the last 5 years, I think most of the manufacturers, the vendors, have now caught up. So the chance of you being able to obtain a good study now, I think, is much more than it was, 10, 15 years ago. So here's a study. I'm not going to say which vendor it was, but you can clearly see the difference between the scans that Fran was showing you. It's really difficult to see the conspicuity of those ejaculatory ducts. It's just a little bit fuzzy. If you want to have a little look at the edge of the gland, again, you can see parts of the edge, but you can't see the rest of it. When you come up towards the sphincter, we can see the sphincter muscle, but again, the edges are blurred. This is not a crisp study that we would like to see on a T2 weighting. It is possible, because the lesion is big, to see the abnormality in the right peripheral zone here based on the capsule. If I show you the coronal view, and again, it's just looking at it, it's just a little blurred. The edges, the conspicuity of everything. So if you can imagine that you can't see the anatomical structures, then you'll struggle to see some of the tumor structures as well. And again, although you can see the seminal vesicles coming into the base of the prostate here, you really can't see the line of the ejaculatory ducts. And we use that all the time as a metric of being able to see small objects. The other thing about this study, this was their ADC map. Let me just see if I can, I was playing with this earlier. And one of the problems that they've done here, see if I can get that to work a bit better. One of the problems that they've done is that the field of view is huge. And so the in-plane resolution is poor. So you're looking at very large voxels, and it's really difficult to identify abnormalities within the prostate when you're looking at a voxel size. Let me get the prostate. So here is the prostate. There we go. When you're looking at a prostate that your in-plane resolution is what here, about 3 millimeters, 3 by 3, very difficult to see areas of abnormality. They've also used the wrong B values. So they've got a 200 and a 600, whereas we would definitely take our ADC up to 1,000. One of the things that we see constantly is people putting long Bs as part of their ADC, which really reduces the resolution of your ADC map for finding tumors. And the other thing that we see is the use of calculated B values, which I might be able to show you if we have time. And again, this was the dynamic study for this particular patient. And one of the things that you can see again is just a huge field of view. This is one of the most common things that we see, is the field of view is too big. The in-plane resolution, therefore, is also too big. And one of the other features of dynamic GAD is that people try and push the scanners too hard. So PI-RADS version 2 allows you to have a temporal resolution of up to 15 seconds, 14, 15 seconds. And you should use all that time if your scanner is a 1.5 or a slightly older scanner. Don't try and get the temporal resolution down to 6 or 7 seconds, because you'll compromise on your spatial resolution and on the visual aspects of your scan. So this is a scan where all 3 sequences were poor. So this is a PI-QUAL 1, PI-QUAL 2, and really non-diagnostic. It has allowed you to see the index lesion, but it won't have allowed you to have identified any of the others within that prostate. I might stop there as we're almost 10 past, Jeremy, but we're, as I said, very happy to come back.
Yeah, no, I think that'd be terrific, Claire. I mean, there's always just so much to talk about in this whole field. So thank you for demonstrating, what perhaps a poorer scan looks like. And there's obviously many examples. I mean, this is the whole, well, not the whole reason. One of the reasons why, we created MRI Pro in the first place was because, well, firstly, obviously there's the scan itself, but then there's also the enormous variability in interpretation. And Francesco alluded to that in one of his slides as well. So there's all these multiple factors. I must say, this has been quite eye-opening for me, because as a urologist, our reflex is to just blame the radiologist for the reporting. But what we don't see up front is all of the technical aspects and the machine problems that you guys are faced with, both machine factors and patient factors, that also need, you know, obviously very close attention in order to get that PI-QUAL score up. So thank you all. Veeru, Francesco, Claire, Richard, Alex, thank you for organising it from the MRI Pro end. It's been another incredibly informative session. So I really appreciate all of your efforts and the cases. Thanks to all of the attendees. We've had about 150 or so people attending this session. So I hope you found it useful. It has been recorded. We will be posting it on the website in a few days' time, but you'll be notified about that by email when that comes up. So if there's bits you've missed, then you can obviously go back to that. But also, you know, tell your colleagues that you've just been watching a very informative and helpful session with all the team from UCLH. So once again, thanks all for joining us, and we look forward to seeing you next time.
Thank you.
Thanks
Thank
a lot.
you.
Bye.
Thank
Bye-bye.
you.
Richard,
Thanks,
thanks so much.
Thank you.
Bye.